So I'm very pleased that Barb's here today to kind of share some of the work that she's done. Barb is a clinical specialist at the Brier Research Institute in Ottawa. She is also the clinical and research coordinator for the pharmacy department at Brier Continuing Care, assistant professor in the Department of Family Medicine at the U of Ottawa, adjunct professor in the School of Pharmacy at U of Waterloo, and Dr. Farrell's research interests include the evaluation of interdisciplinary collaboration, a common theme in deprescribing, pharmacist activities in identifying and resolving drug-related problems in deprescribing programs. In 2011, Dr. Farrell was named the Canadian Pharmacist Association's Pharmacist of the Year for her work in pharmacist education and patient-centered care and research. So it's my great pleasure to welcome Barb to the stage today.
Thank you very much, Jeff. So I want to start, first of all, by acknowledging our funder for the research that I'm going to be presenting, the Canadian Foundation for Pharmacy, through one of the innovation research grants. And also give you a sense of where we are in the project. We've just completed the pilot, and we're in the process of finalizing our final reports for Dale, as well as our publication draft. Jeff spoke a little bit about my interest in sort of the business side of things as well, and I think that stems a little bit from having grown up helping out in my uncle's pharmacy and sort of hearing a lot about the conversations of the business challenges, et cetera, and even in latter years as he moved on from owning the pharmacy. Over the last 20 years, I've been working in a geriatric day hospital in Ottawa where I see frail elderly patients who are often taking multiple medications, and we work within an interprofessional team. So that's where a lot of my research interests in helping the frail elderly has arisen, in particular using interprofessional approaches. So in this presentation, what I want to do is talk just a bit about how deprescribing contributes to managing problems with polypharmacy, especially in the elderly, and share some findings from the recent study that we've completed, the Community Pharmacists in Deprescribing pilot. And then tell you a bit about the study process and what we've done to try to draft a business model. So the problem that oh dear, we're locked inside the room. That's not good. All right, so the problem that we're trying to solve is really that of polypharmacy. So for those of you who are pharmacists, you've probably seen this in the pharmacies, people on sometimes 10, 20, I see patients on 30 medications sometimes. I know, hopefully you don't have family members that have experienced that, but I know a great many people tell me that their family members suffer with polypharmacy. And so the problems we run into are associated with side effects from those medications, drug interactions, prescribing cascades where one drug gets started to treat the side effects of another drug. We know that the more drugs that you take, the more non-compliant people become, and this is both unintentional non-compliance, forgetting because the regimen is too complex, or in about half of cases, intentional non-compliance because people just get sick of taking medications. The medications contribute to functional and cognitive decline, falls and fractures, hospitalizations, ER visits, and so they represent a great cost to the system. The problem is big, not just in Canada, but around the world. In Canada, we know from Canadian Institute for Health Information data that about 2/3 of seniors are prescribed at least 5 prescription drugs. That used to be considered the definition of polypharmacy, was taking more than 5 medications. It gets even more, I think, concerning when we look at how many people take more than 10 medications. So a quarter of people over 65 years, 40% of people over 85. And people over 85 are the group in whom we don't actually know if the drugs are working because those people never get into the drug studies to start with. And 66% in long-term care homes, so that's a big concern as well. Steve Morgan published a great paper in CMAJ about 2 years ago, estimating the amount of money that we spend in Canada on potentially inappropriate medications for the elderly at around $420 million. And when you estimate the incremental health care costs associated with the adverse effects, particularly falls and hospitalizations for adverse effects, you're looking at over $1 billion a year that we are spending. Just to give you a sense of the risk of falls, because this is one of the things I see in my geriatric day hospital practice, is that people get referred because they're having falls at home. We know certain medications contribute to falls, but we also know the more medications you take, the higher is your risk of falling. And I'm going to go back quickly just to this picture here. If you can picture that, this is what I see every day in the geriatric day hospital, is people who are just overwhelmed and sick of taking medications. So we really look at what is the benefit of the medication they're taking and what are the potential risks or harms. And that's where deprescribing comes in. So we define this as the planned or supervised process, to differentiate it from just not taking your drugs, of dose reduction or stopping a medication that might be considered to be causing harm or might no longer be of benefit. And the goal, of course, is to reduce the medication burden and harm, but still maintain or improve quality of life. And I like to say that deprescribing is really just part of good prescribing. It's, people have been doing it for years as part of their prescribing processes, but not everyone does it, and that's evidenced by the patients, that we see that are on these huge numbers of medications. As a research team and the clinicians around the team, we all believe that community pharmacists are positioned to champion use of deprescribing guidelines, and that was the premise behind us wanting to do this project. So one of the things our research team has done over the last 5 years is develop a process for creating evidence-based deprescribing guidelines, using the same kind of approaches teams use to create prescribing guidelines. And we thought that since prescribing guidelines never seem to have sections in them about when to stop the drug, that it would be helpful for us to create guidelines about when it would be appropriate to stop a drug and how to stop the drug. And you can read a lot more about these individual guidelines as well as our methodology by going to our deprescribing.org website, which links you to the guideline publications in Canadian Family Physician, as well as to these different summary algorithms. So when we created a guideline, each guideline is sort of 5,000 to 7,000 words long, which we knew that clinicians would probably never read. So we summarized the key important steps of the guideline into these algorithms, which people have found very useful in practice. And we had done some pilot work in long-term care and family health teams, and we're getting a lot of positive reaction. And that's where we thought, well, we were also getting a lot of questions, for example, at the CPHA conference from community pharmacists saying, I'd like to try to use these in practice, but how do I do it? So that's where the idea for this study came about. The other question, in addition to how do I do it, is how do I make this into a cost-effective use of my time? So we wanted to explore that as well. So we wanted to look at if and how deprescribing practices could be integrated into the pharmacy workflow if we gave the pharmacy teams training on how to use the guidelines. So we worked in this study with 4 community pharmacies, 2 in Ottawa, 2 in Toronto. And in addition to working with the 4 pharmacies, we put together an advisory group that included people from the Ontario Pharmacy Research Collaboration, as well as representatives of national health insurer or health payer or insurance payer organizations and national pharmacy provider groups. Then on the advisory group, we also included a pharmacist from each of the 4 pharmacies, and then the researchers or the co-investigators as well. So what we wanted to do over the course of this it's a 1-year grant, so we wanted to actually have our piloting over the course of about 6 to 8 months of that time. We wanted to try to quantify the opportunities for deprescribing within the pharmacies, describe the activities and processes that were associated with the guideline use, including how long the different activities took, and then what were the facilitators and barriers that were encountered. So what we did was we used iterative observation periods and PDSA cycles within each pharmacy, and then after we had observed what they were doing in the pharmacy, we came back back together as a group with the advisory group, reviewed what was happening, made some decisions about whether or not some changes would be done for the next iteration. Then we went back and observed what was happening in the pharmacies again. And our goal was to try to draft the components of a business model based on these results. So we had sort of 3 levels of data collection. One was around quantitative data. So what were the opportunities? What were the actions that were taken? What were the outputs in terms of pharmaceutical opinions or other materials or resources that were developed, as well as an online survey to give us some feedback about the training materials we provided. We also collected qualitative data by, as I said, having the researcher actually embed themselves in the pharmacy and observe what was happening around the deprescribing activities. And that was done 2 or 3 times during the course of the pilot in the different pharmacies. And then we took those observations and the field notes that were written by the research associates, and we analyzed those to obtain better descriptions of what was happening. And as I mentioned, we did the PDSA cycles and had an investigator work with each pharmacy individually to develop their PDSA plan and then reviewed the results of that at the advisory group level, and then again had the co-investigator work with the pharmacist to continue to implement a second cycle. So in terms of our findings, what we found across all 4 sites was that deprescribing was feasible, and I think this is probably not surprising because, of course, we were looking for volunteer pharmacies who were interested in doing this. They were all able to identify individual goals and plans for their PDSA cycles, and there were some commonalities that I'm going to describe in a second. And they were all able to identify sort of a workflow model that worked for them to implement the deprescribing activities. Their practices differed by site, and I'll give you a little bit of information about that. And each pharmacy did, or not each pharmacy, but some pharmacies developed resources and materials at their sites to integrate deprescribing. So what we identified were that there were these 4 common steps that they all used. The first was capacity building activities, and a lot of this had to do with staff education. Not just the pharmacists, but the pharmacy technicians, the students, the front shop staff. They tended to educate all of their staff about the project and about why they were involved and what it might involve. They all, to some extent, used students as part of their capacity to implement the activities, and they all had different methods to identify or attract potential patients for the deprescribing activities. In terms of preliminary interactions, this tended to be a triage kind of activity where either the, say, front shop staff might talk to clients coming in about the potential for deprescribing, or it could be done, say, at the refill stage, or it might be done by having students or staff go through the database and identify people taking a specific drug and then calling those patients. So that's what the preliminary interaction sort of looked like. In terms of the detailed interaction with the pharmacist, people who were thought to sort of qualify as a candidate for deprescribing were then either seen by the pharmacist for an unscheduled type of meds check or asked to come in for a scheduled medication review or meds check. And that interaction then resulted in documentation of the meds check, as well as, in some cases, documentation of a pharmaceutical opinion. The follow-up and monitoring stage included the sometimes repeated faxes or calls to the physician, and there were cases where, you know, it took 3 or 4 times to get a response back from the physician about the pharmaceutical opinion that had been sent, and then also to track follow-up and patient outcomes. So in terms of the facilitators, what we observed was that having supportive staff and students that were motivated was very key, obviously, to making this feasible. The on-site educational initiatives were important. employing a collaborative team approach, so using all the members of the team, not just the pharmacist, and also enhancing patient awareness and education around the risks and options to reassess their medication. I want to go back for a second to the on-site educational initiatives to describe those in a little bit more detail. So what we had provided were those algorithms that I described earlier, as well as whiteboard videos that we had started to develop on how to use the algorithms. So these were sort of 8 to 10-minute videos that went through different sample cases and walked people through the algorithm. So those were available online for 2 of the guidelines. We had created those to date. The other education we provided was access to an online module that's hosted on our Briere website, and the link for that is in one of the earlier slides. It's you can find it easily by Googling Briere Polypharmacy Deprescribing, and it's a free online module created for students. But in this case, the pharmacists and the staff members were able to use that to kind of understand why polypharmacy was a problem and why deprescribing was important. The other thing that arose very quickly in the course of the pilot was that the pharmacy staff, so the 4 pharmacists that were on the advisory committee, wanted to be able to train their staff about the project. But they said they had to keep repeating it because there was like a new staff member who would join, or people were on different shifts. So they asked us to make a YouTube video describing the project and why we were doing it and how it would be done over the next year. So we did that and created sort of a 7-minute YouTube video, which made it very easy to train staff at the sites. So the last facilitator on this slide is this concept of having a standard template. And so nearly all the sites created some kind of standard pharmaceutical opinion template that they could use to send off to physicians. In terms of barriers that people ran into, it's probably no surprise to say that we're competing workload demands and extra time, obviously, to do this kind of discussion with patients. Staff turnover and new staff training was a barrier, and that's why we developed the YouTube video for people. Communication delays, lack of response from prescribers. This was kind of interesting, and there's a follow-on on the next slide, in that to address this barrier of not getting feedback about your pharmaceutical opinion, a couple of the sites found that when they started attaching the algorithm to the pharmaceutical opinion, they got instantaneous responses. So it was having that, extra level of credibility, or even just a rational explanation that was clear, that made it a lot easier for the healthcare provider to respond. It was challenging sometimes for patients who were uncertain about it, or wanted to go and talk to their doctor, didn't want the pharmacist to fax the doctor. Then, of course, there were patients who were identified in some of the database reviews as being eligible for deprescribing, but they never came into the pharmacy because they had things delivered. And so that created a bit of a challenge as well. There was some feeling that there was some duplication of documentation if you were both documenting it in the meds check and for a pharmaceutical opinion. There was some, discussion around what would be an appropriate compensation model for deprescribing activities, and challenges related to workspace. So in terms of successes, there was one pharmacy in particular that had a lot of success bringing patients in. So they actually put a sign outside the pharmacy, like a sidewalk sign, saying interested in deprescribing, or do you still need all your medications, and window signs, and that brought a lot of new customers who had never been to their pharmacy before into the pharmacy. So they thought that was quite successful. That same pharmacy also put information on their website about it. They sent out targeted emails to their patients. They put an ad in a small local newspaper. So they tried a variety of things. Another success, and this was identified by all the pharmacies, was just training all the staff to field questions. It was probably most important for that team that advertised externally, because they would have people come in and ask the cashier, what's that sign outside mean? So everybody had to be trained to respond and to sort of triage and field in order that the people who ended up going and asking the pharmacist were the people who were actually eligible. Using standardized templates, as I mentioned, faxing the evidence or the algorithms along with the pharmaceutical opinion, and also engaging students and other support staff to share the deprescribing workload. So recognizing that if it's only the pharmacist who can talk to people about this, then it becomes very expensive. But if your front shop staff and your pharmacy technicians can help you to triage patients, then that is a more cost-effective, I think, approach. So our next step was to take all of this information and try to develop a business model. And I want to acknowledge all the members of the advisory committee, first of all, but especially Jeff for his advice on how to take the different components we had learned about and integrate them into a business model. So what I learned a lot in this process as well. And the business model, or the framework that we've developed, I feel it is sort of a link between the strategy of, wanting to help people to reduce their medications if they're harmful or not needed, but also the business organizations and the systems within which they're working. So the way we developed it, again, was through these iterative observations in the pharmacies, the discussion with the advisory group. We did this in a very, I think, rigorous manner from a qualitative research perspective in terms of having at least 2 people review all of the data and develop themes. We have attempted to try to take the components that we've identified and integrate some quantitative data. And I would say that's probably the biggest gap in what we've done, because when we set out to collect quantitative data, we weren't 100% sure what the pilot pharmacies would want to collect, what they would value. So we let them organically collect data, and then what we found was that there was a lot of variation in what they actually collected. So that's something I think that moving forward, we want to put a lot more effort in. In terms of the components of the business model, we started with a value proposition that was really around this belief in optimizing medication through targeted deprescribing to manage chronic conditions and avoid adverse effects and improve health outcomes. And then we collected information and summarized what looked to be the key partners, and those included, the pharmacists, all of the front shop staff and technicians, the students, the patients, and the different healthcare providers or prescribers with whom they were corresponding. We then summarized in the business model the key activities, which were those 4 stages that I described earlier, as well as problem solving that people did through the PDSA cycling. And we identified the key resources, being the human resources, the physical resources, as well as all the intellectual resources that we had both collected and provided. We also included in the framework customer relationships, both the acquisition of new patients, which we found happened in that one pharmacy, as well as the retention of patients, and then the different segments. So for example, those 4 guidelines are specific to proton pump inhibitors, benzodiazepines, antipsychotics, and antihyperglycemic medications. So the different pharmacies targeted different populations amongst those 4 groups. And then for the framework, we also considered the channels to identify patients, as well as the value-driven cost structure and the different potential revenue streams. To tell you a little bit more about the 4 pharmacies, as I mentioned, the one pharmacy did quite a bit of external advertising, and they costed that for us, which was helpful. So just as one example, the pharmacy that did the newspaper ad, it was $260 for the newspaper ad. But then when they asked, I think they had 76 patients overall, or 78 interactions with patients about deprescribing. One of those people came in because they saw the newspaper ad. 26 of those people came in because of the sign on the street. So it was really helpful to kind of figure out what might be more effective. And it's only one pharmacy, though, so we don't know how generalizable that is, but it's helpful information. In terms of targeting the specific drug groups, most of the pharmacies chose to start with the proton pump inhibitor deprescribing guideline, and about half of the patients that we're seeing were for the benzodiazepine deprescribing guideline as well. So PPI, benzodiazepine. The antipsychotic one was not as commonly chosen as the initial guideline to start with, and nor was the antihyperglycemic. So in terms of targeting, as I said, the one pharmacy focused on bringing people in, asking people to self-identify. The other three pharmacies identified patients by looking at their current clientele. One picked their long-term care home patients for whom they were already doing med reviews. And then the other two pharmacies chose to have students go through their databases and, for example, identify all the people on PPIs and then start phoning them. So there were different approaches that they all used in terms of trying to identify potential patients. In terms of the interactions, so remember this is sort of over 6 to 8 months, and there was an initial time for education, and then we had these 2 or 3 observation periods. The first pharmacy reported they had done 13 medication reviews in which deprescribing recommendations were made. The second pharmacy identified these 78 interactions, of which I believe about a quarter resulted in an actual pharmaceutical opinion with medication recommendation being sent to the physician. The third pharmacy did not collect data related to the numbers of patients that they screened, but they approximated that they thought about a quarter of the patients who were screened had a pharmaceutical opinion that eventually went to the physician. And then the fourth pharmacy identified, I think, 59 patients through their database review, for whom 23 meds checks were completed, with about half of those resulting in a pharmaceutical opinion. So they weren't huge numbers of patients for whom recommendations for deprescribing were eventually made. And this was, I think you can kind of take it both ways. It's an early pilot, so it's hard to know if those numbers might increase as the practice became more common. But it was also a little bit reassuring that it wasn't a massive amount of time that people were spending on this, because there weren't that many patients who actually, clearly met the criteria and needed a recommendation made. So the pharmacists provided a lot of really positive feedback. They spoke about the confidence, not just of the pharmacists, but their whole team in terms of talking to patients and recommending the potential for deprescribing, and that they thought that confidence came across really clearly in establishing patient buy-in to working with the pharmacist on an initiative like this. One of the pharmacists was really thrilled because he had been doing a lot of work in trying different approaches to business models, and he had done a lot of innovative things in the past, but this was the first time he'd ever worked with researchers and people in academia, and he was very pleased to have that support. And then just the professional commitment was very clear amongst all of the pharmacies. So I think what we've learned from this process is that, and you know this, that the pharmacies are diverse and they're distinct in nature. There's not really a one-size-fits-all approach, but we did determine that it's definitely feasible, but that you need flexibility and planning. So we're happy that we didn't start out the project by saying, thou shalt do it this way. It was much more effective find out how they would do it and then help them to facilitate that. And so going forward, what we would like to do is a larger demonstration project. Now we have some sense of what type of data the pharmacies would be interested to collect. And so we'll be able to design a data collection approach that will be more feasible. But I think we also know that there'll be some value in having a coach or a mentor in terms of the development of these PDSA cycling approach, which seems really effective. So the business models that we created, the framework, I think, because it's based on such a small sample size, it does give us insight into the process, but it didn't really give us exact financial figures on what to plug into that model. And so that's where the next demonstration project, I think, is going to be really valuable. So that's our hope, is to now write a proposal to do a larger demonstration project with a larger number of pharmacies to test the components of the business model so that we can actually produce something that, that will be really usable for people. In the meantime, we are working on a publication for this project that will include that business model canvas so that other people can work with that as well. We've also done some videotaping with the pharmacists that were involved in the study, and we're putting together a little testimonial video that'll be available on our website. I mentioned earlier we had the 2 whiteboard videos. Everybody loved those for using the guidelines and asked us to create 2 additional whiteboard videos for the other 2 guidelines. So we're in the process of just completing those now. One of them, I think, went online last week, and the other one's just waiting for me to get over my cold so I can do the audio for it. So hopefully in the next couple of weeks. So if you're interested in reading more about the research related to the deprescribing guidelines, it's on the open website. I encourage you also to follow us on Twitter. We've got about a little over 6,000 followers internationally, and lots of discussions on how to move this forward. And you can find all of our resources on the deprescribing.org website. So links to the publications, the algorithms, patient pamphlets. We also created infographics that can be used as posters. So something you could put up in the front of the pharmacy to say, hey, are you taking one of these drugs? You might want to talk to the pharmacist about whether or not you still need it, et cetera. And there's also a lot of other links, including to the Canadian Deprescribing Network there. So I'll stop now and just take some questions. Yeah?
First, did the patients stay deprescribed, or did any cycle back onto medication?
So that we don't know because we didn't collect patient information. So in this type of small study, we weren't able to, submit a research ethics board submission and have someone who would be there to consent the patients to participate in the study. So that would be part of the next study, the larger one, to get patient outcome information.
And second, this is great work that you're doing, and I'm wondering, not just for yourself, but Jeffrey and Glenn too, is there a coordinated effort to look at either tapering algorithm or deprescribing on opioids as a collective?
Yeah, so you're like the 5 millionth person that has asked me that question. So it's challenging. The process we used to develop the deprescribing guidelines included doing a systematic review on deprescribing studies for the target drug. So there's lots of deprescribing studies in opioid withdrawal, but it's very challenging because the patients are also different from each other. So we actually held an international deprescribing guidelines symposium last week in Ottawa, a 3-day symposium. So we had about 130 people from 9 different countries, and there was a group that worked on steps towards developing an opioid deprescribing guideline. But their initial meeting would have been about, how are we going to limit the scope of this? How are we going to get funding for this? We've estimated that it costs about $100,000 to develop each of those guidelines. So we'd have to get funding, we'd have to put a team together. It would take about a year or 2 to develop one, but I know there are definitely people who are interested in doing that. Dale?
In the planning and sort of the engineering how different were the approaches of the 4 stores in terms of patients and how it fit into their workflow, et cetera?
Well, as I said, there were those 4 common steps. The differences were in, I think, how they identified the patients. So self-referral from the sign versus getting a student to go through the database and identify all the people on PPIs and then phone them and tell them to come in. So that was quite different. Who was interacting with the patients was different. So the one pharmacy started out by using their whole team, their front shop staff, everybody. The other pharmacies didn't do that initially. They just thought only the pharmacist needed to know. But then when they heard that the other pharmacy was engaging other people, the whole team in the process, they decided to also use that approach. So that was kind of the value, I think, of having a pharmacist on the advisory committee. The other thing people learned through that was that there was another pharmacy that had taken the step right almost from the beginning of including the algorithm when they sent the pharmaceutical opinion. The other 3 pharmacies didn't think of that, but they discovered it when we had the advisory group meeting, so then they started doing it. So I think that was kind of the value of having this cycling and reviewing what we were doing.
And the funding potential does more or less come from the sort of completion of pharmaceutical opinion? Was there anything else in there that would...
Well, the meds checks that were done, the pharmaceutical opinions that were done, the one pharmacy estimated that, they got 26 new clients because a lot of those, I think almost all of those people switched to their pharmacy. And there were a lot of what they call knockoff sales for OTCs. So for example, someone who is tapering a PPI, they might recommend that they get some Gaviscon in case they have some rebound heartburn, that kind of thing. Vitamin sales for people who are on PPIs. It's melatonin instead of a benzodiazepine, those kinds of things, but we weren't, we haven't specifically quantified that, but that I think would be something in the demonstration project. The one pharmacy that had people, that advertised for people to come into the store, their appointment with the pharmacist, if it was more than a meds check, so if it was a full medication review, they charged the patients for that, and so the patients paid. I don't know exactly how much they paid. That's in our data somewhere. But yeah, and that pharmacy charges for consultations anyway, so it wasn't a big stretch for them to do that. Mm-hmm.
I just wanted to clarify that you mentioned that about 78 people came in one location. That was the kind of pilot size, right, per location on average?
That was one of the pharmacies. Okay. It said they had 78 people who that they had interactions with, but they weren't necessarily all people for whom deprescribing was appropriate, but they did count how many people they talked to.
I see, and that would be the new people, the existing patients or new patients, right? And the 25 or 28 were, attracted via a sign you mentioned. That
yeah.
New patients or also might be existing patients? Right?
That's a good question. I'd have to go back and ask them that. Right. Yeah.
I have a question. Regarding funding and exploring potential funding for this sort of thing, regarding the opiate market, people on, say, say Suboxone or a methadone program, there's a daily dispensing fee associated with that.
Okay.
So I was wondering if you guys have explored, or if there's any sort of, if you're exploring the aspect of perhaps a pharmacy that is working with someone to taper them off of Suboxone or methadone, if they could then be, maybe the funding could be the sort of witnessing fee that they're getting now. And that could be sort of moved over to the tapering off process, where the pharmacists have an opportunity to really, exercise their professional services, right? And I mean, of course, if you can get someone off of an opiate, we know what costs are associated with letting that run amok. So I was just wondering if there's any sort of exploration and looking at the fees that are given now for witnessing and the compounding of methadone or whatever, Bethel space, if it could be moved over and diverted to the same fee to a pharmacy that's working with someone that is coming off on these programs.
Yeah. that's a good idea. I could see that that would also work for the benzodiazepine tapering too, which often needs a fair amount of support. Yeah, so we're having, you know, this is one of the reasons why we included the insurance payers on our advisory group, to keep them engaged in the conversation. But through Open and also through some of the specific deprescribing work we've been doing, we've been having lots of conversations with people at the Ministry of Health and ODB about the potential for different models of compensation that would support this. So that's a really good idea, because I didn't know about that observation fee. So that's helpful for me to know going forward.
Pharmacy, they get, I don't know, it's quite expensive what they get.
Okay.
To witness the consumption of methadone.
Right.
So they're getting a daily fee
Yep.
for that.
Yeah.
So there'd be, it's an immediate savings, I'm sure, that can be demonstrated, but still make it valuable for the pharmacy.
Yeah.
Yeah. Anyway.
Yeah. No, that's good to know. The more that I know, like those sorts of ideas, the more I can discuss when we're.
We'll talk all about it.
Yes.
Just have a quick question. So thank you for this, actually, for sharing this. Just around when you embarked on this research, did you have pharmacists come back and say, deprescribing this means reduced prescription volume in my pharmacy? Has that ever come?
So not for this project. All 4 of these pharmacies had contacted us previously and said, can we be involved in your research somehow? So we've got sort of a big pool of people who've already approached us. So it was pretty easy to identify people. I've had people raise that question, but they always say, have you ever had a pharmacist say this? Nobody's ever said to me, my pharmacy isn't going to do this because we believe we'll lose money. It's always, have other pharmacies ever said this to you? So it's kind of interesting. I work with a... Yeah, I work with a colleague, Justin Turner, who he's a pharmacist from Australia, owned a community pharmacy for 10 years, then went back and did his master's and PhD, and is in Canada doing a postdoc in Montreal with the Canadian Deprescribing Network. So he told me that he started doing this deprescribing stuff when he co-owned this community pharmacy in Australia with 2 colleagues. And it was because he was working in long-term, they were servicing a long-term care facility, and he was seeing all the overuse of medication. And so he started talking to patients about, you know, I'm not sure if you really need this anymore. And the other 2 partners got really mad at him and said, you know, we're going to lose money if you keep doing this. And their prescription volume ended up going up because so many new clients came to their pharmacy because they earned this reputation of actually caring about how you were on your medication. So I'm not...
No, it's the right thing to
Yeah.
do. And I
Yeah.
understand that professionally, yes, we think that, but from a business standpoint,
I know.
have you looked at it?
Yeah, so that's why we thought it would be helpful to develop this kind of business model framework. And I think then the next step is kind of, I don't know, validate the framework and collect data that we can actually plug into it in terms of numbers.
So I'm interested, I'm happy that you had insurers at the table. How do they respond to this? Because really, you know, the beneficiary, apart from the patients, we would all recognize them, and you're quite right, there's the professional pharmacy who wants to do the right thing for the patient, and there's the business department that's really under tremendous pressure right now. So those 2 are, but the real financial benefiter here is going to be the payer, who's no longer going to pay for those drugs. In some cases, you know, PPI could go on for 10 years. So what was the input, or what did you hear from them?
So that's a good question. Did you have a sense, Jeff, from the advisory group?
You know, I do remember, you know, the one advisory group meeting that, in particular, the payers, of course, were supportive. You know, and there were a number of, you know, private insurance companies that were on the, and of course, as you would expect, they were supportive of it. They were a little hesitant to say, oh yeah, I'm supportive and I'm willing to pay for this.
Yeah, that's really, what does that support mean?
Yeah, they weren't quite willing to go that far. And I think, you know, I got the sense that, you know, they're sort of hoping, well, maybe the government will pay for it.
Yeah.
You know, I don't want to commit that I'll pay for it, but maybe the government will pay for this. So I think the challenge is that you know, the business foundation for this is not quite clear yet. But what I like is that this work is I think critical to developing at least the business model and the framework around how you can show the benefits, and then you can come back to the payers now and say, okay, now we know more about what the benefits are and what the costs are of doing this, right? Because there are costs for pharmacy to engage in this, above and beyond the cost of the drug that they're no longer getting, right? So there's dispensing fees, foregone, et cetera, et cetera. I think, to sum it up, I think payers will be open to having a discussion, but the private payers in particular, they want to see some evidence.
So this is the first time we've had the payers at the table in a research project. So it is, and we had, I think, 3 advisory group meetings over the course of the project. That's why I'm hesitating a bit in terms of saying what their specific reaction was. But they were at the table. They will get the final report. Our next step will be to follow up with them. We might be able to get funding from some of them, because our next challenge is, where are we going to get funding to do a bigger study? So they might be interested in supporting that.
Could be, I think, an interesting place to really challenge the landscape on this claim that what we're after is value-based work versus volume-based work, right? Because there will be, if we can get the numbers crunched, a measurable value that you attach to this, which is probably far beyond, you know, a dispensing fee, or, you know, so how do you assess that value? It'd be a great place to test it and see what really happens.
Yeah.
You know, up to now, we don't really know.
Yeah.
We're saying this, we're talking about the value-based model, but today we're still incenting the volume-based.
Yeah. And moving forward, too, we would include in our next steps a health economist on the team to make sure that we can do that properly. Dale?
And just a sort of build on that was that having the insurers there would, you know, great from an observable and sort of, was there anything interesting or unique that they actually brought to the table in terms of perspective on the study?
I think they probably listened more to what was happening in the pharmacies than added a lot.
Oh, it is. I just thought, you know, they would have a different view of it as well. So, I mean, so
Yeah.
there's great value in having them there from an educational
Yeah.
standpoint and sort of taking the journey with you. I
Yeah.
just was curious if there was anything that stuck out in your mind that had actually sort of contributed to your thinking
Yeah.
about how you approach this.
Well, I think my next step would be, like, once the final report, which Dale is waiting for, is finished, you will obviously get a copy, but so will the advisory group members. And then one of our next steps will be to follow up with each of the members of the advisory group about the report and say, how do you see this fitting in? So I think that's the kind of step that makes me not able to answer your question very well, because we haven't done that follow-up yet with each of them.
And will the public here see it as well?
Yeah, yeah,
Great.
yeah.
I think the key thing is, you know, ultimately in my mind, I always want to jump to, okay, what's the policy implication? You know, like, how do I go to ODB, for example, and say, you know, this is how we change the model and come up with something new? We're not quite at that stage yet, and I think the challenge is always that you know, there's some uncertainty about the numbers, and what's really great about this work is it's leading us towards numbers so that we can have quantitative discussions with payers, and that will lead to policy options, right? There's all kinds of ways, creative ways we could do this. You could look at a shared savings model, you know, look at like how much money is the payer saving over 5 years, and let's share some of that with the pharmacist who's doing the de-prescribing. So, but we can't quite have those conversations yet because we still need some more specifics.
But some of those have started to change. So just from a medication synchronization, so that's a very tactical piece of work in the pharmacy. But what some of the payers are doing is, because the first painful step with synchronization is the short fill, aligning all those medications for the same day. That involves work from the pharmacy, but payers don't pay an additional fee for that. But some of the third parties are picking up and paying for that first short fill because they see there's benefit at the end of that.
Right.
Right?
Right.
So this is a good time to engage the private payers because in Ontario with the OHIP Plus, I'm sure they're saving some money because the government is picking up the first piece, right? So before they forget about that money that they have saved, we should start to engage them and say, hey, you know what? You may want to pay fee for service for the pharmacist to manage that.
It was helpful actually listening to Michelle Romanow speak this morning and talking about all the failures before she got to the success and how you learn from each one. And I don't think this is a failure, but it is a step in the direction of an innovation.
It might be too early. You showed some stats there in terms of the age of patients and like 27%, 65, and then
right.
at 80 it was like 40%, et cetera. Because part of the interest I would expect from the private payers would be folks that are still working. So
right.
Do you have any stats in there in terms of the number of patients that you would have helped that would have been under 65? I know it was a limited pilot, but I just was curious.
No, we don't have, because we didn't have Research Ethics Board approval to actually collect patient data, we couldn't collect things like age or sex or gender. Yeah. Thank you, everybody. I'm here for a little bit if you have more questions.